gegnum tíðina að því við teljum að þessi þróun sé andstæð almannahag. Og við höfum lýst í yfir ítrekka að við erum alfarið á móti markaðsvæðingu heilbrigðisþjónustunnar og gjaldtöku sem að byggja á hagnaðarsjónarmiðum. Og rannsóknir sýna líka að þar erum við að tala fyrir hönd þorra þjóðarinnar. Og að þessum markmiðum höfum við í gegnum tíðina, bæði saman eða sikkur lagi, ASI, BSRB og BI, staðið fyrir rannsóknum, skoðanakönnunum, greiningum, fundum og svo mætti lengi telja. Og þannig var það að árið 2005 þá hélt Göran einmitt erindi hér á landi kosti og galla mismunandi rekstrarfyrirkomulags í heilbrigðisþjónustunni. Og það erindi var gefið út í riti og þessi varnaðarorð hans þau vöktu verðskulda athygli hér á landi að því að niðurstöðurnar voru afdráttarlausar að einkarekin heilbrigðisþjónusta sé dýrari fyrir skattborgarann og óhagkvæmari fyrir samfélagið í heild sinni heldur en heilbrigðisþjónusta sem rekin af opinberum aðilum. Þar kom líka fram að einkarekstur auki mismunun og komi sérstaklega illa við lágtekjufólk. Með þessari útgáfu á ritinu þá spáði Göran fyrir aukna markaðsvæðingu heilbrigðiskerfisins sem hefur raungerst í Svíþjóð á síðastliðnum 30 árum. Og svo við horfum til dagsins í dag að þá hefur Göran ásamt Lísu gert nýtt rit afleiðingar markaðsvæðingar á heilbrigðiskerfið í Svíþjóð og ritið þeirra Jämlik vård en handlingsplan eða Jafnrétti í heilbrigðisþjónustu sem hérna frammi og líka aðgengileg fyrir þau sem eru að fylgjast með á netinu bara á heimasíðum okkar, ASI, BSRB og BI. Og það tilefni auðvitað þessa fundar í dag að við sjáum að svo verið sem að þróun heilbrigðismála hér á landi sé að stefna í svipaða átt eins og í Svíþjóð með útvistun aðgerða frá opinberri heilbrigðisþjónustu og aukinni einkavæðingu. Og það ákveðin pólitísk öfl sem að hafa róið undir og í þessu sambandi gjarnan að vitna til Svíþjóðar sem fyrirmyndarlandsins. Þannig að þá auðvitað best að heyra bara frá reynslunni þaðan og það kunna það fáir betur heldur en Göran og Lísa sem verða með erindi hérna í dag og svo verður líka spilað erindi frá Rúnari Vilhjálmssoni sem að gat í miður ekki verið með okkur, hann erlendis en við fáum upptöku þar sem hann mun setja erindi þeirra í samhengi við reynsluna hér á landi. Ég hafði hugsað mér að kynna bara hvert fyrirlesara fyrir sig, en fyrst vil ég þá kynna Göran. Hann sænskur sérfræðingur í lýðheilsumálum og handhafi lýðheilsuverðlauna Norðurlandaráðs árið 2003 og síðan á 9. áratugnum að þá hefur hann verið áhrifamaður á alþjóðavettvangi á sviði heilbrigðis- og lýðheilsumála. Göran fyrrum gestaprófessor við Háskólann í Liverpool og var yfirmaður heilbrigðissviðs sænska félagsmálaráðsins og lýðheilsuráðs sænsku lýðheilsustofnunarinnar. Og hann hefur líka starfað á alþjóðavettvangi fyrir alþjóða heilbrigðismálastofnunina. Og erindi hans ber heitið When the Swedish healthcare system became a market, driving forces, effects and alternatives eða í mjög lauslegri þýðingu minni hvernig sænska heilbrigðiskerfi var að markaðsafli, ráðandi hvatar, afleiðingar og viðbrögð. Og þá býð ég bara Göran fyrstan á svið. Göran, the floor is yours.
Thank you very much. Thank you very much for the invitation and for translating the book. I understood that was what you said. First of all, I would like to recall two important universal truths. The first one is that people who are financing their health services via taxes, they are not doing it to promote profit for the owners of the place. They are doing it because they need care and they think that the tax financing is the best way to secure that the care is there when they really need it. And in spite of that, so many healthcare systems are infiltrated by profit interests and making it an objective similar almost to the need of care and competing with the need of care objective. And that is found in many countries, and I'm going today to talk how it has interfered into the Swedish healthcare system. The second truth is that when you introduce health sector reforms, you are inviting the market forces to take over from democratic forces. And the market forces, they are sometimes described as the invisible hand. And the invisible hand is known to be very good to use when you want to transfer resources from lower income groups to higher income groups. They favor profitable things, and they try to avoid unprofitable things. And unfortunately, when you transfer that into the healthcare system, some of us here, especially if they are elderly like me, we are unprofitable on the market, and others are more profitable, the younger ones and the better off ones typically, while the low-income groups are known to have a greater disease burden. So the fantastic thing from a conservative point of view with the invisible hand is that he can do that, or she can do that. I'm not quite sure about the sex of it. But anyway, he or she can do that without any political decisions. And they can transfer the money from lower income and middle income groups to higher income groups and the resources of healthcare in the same direction without any political decision. And that is, of course, a great advantage for those who want this change, because they could rarely do it in an open democratic process. It would be rejected if you said, I want this to be changed in this direction. But when you can say the market, and then it is fixed in a more smooth and secret way, and it is according to your wish anyway. So these are the first two truths that I would like to mention when talking about the reform process in the Swedish healthcare system. And I then wonder, where do we find the main driving forces for this change? Well, the first one is commercial interests. And in Sweden, they have been very, very smart and very successful in actually convincing politicians that by inviting private for-profit providers, they can achieve many, many positive things. But for them, the commercial providers, of course, the main objective, as for any business, and I'm not criticizing them for that, is to make good profit. And the healthcare market, which is tax-financed, is an almost ideal market. It's huge, it is safe, it has no fluctuation, the demand is increasing, and you will always be paid. It's a very trustful payer. So it's difficult to find any market that from a commercial point of view is equally good to perhaps in the field of education and other welfare services. But in the normal commercial market, you take much greater risks as compared with the tax-financed market. And they get the support of the from the conservative and the neoliberal parties in Sweden. And they do it because it favors their voters, basically. I mean, it's a class issue. And where are the counterforces to these movements? The Swedish Social Democrats, and I'm not a politician, I'm a researcher, and I've been a civil servant, so these are my roles. But when I'm looking at the Social Democrats today, I feel that they are pretty weak as a counterforce. They are split within themselves. There are some members who are reluctantly sometimes, but they are accepting and they are not protesting anyway. And there are other members who are negative and outspoken. But when it comes to the party congress and when they are setting down their policy, they are very strong in criticizing it in ideological terms, but they're very weak in coming with specific proposals that will change the system. So the left party and the Workers' Labour Union, they are more precise in their critique and they have more of an alternative than the Social Democratic Party. But they are, of course, not major players in the big game here. Perhaps they could be if they were even greater and more active. And Lisa is going to, in the next presentation, to describe to you the work done and the attitudes within the various labor unions in Sweden. Where is the general public? Well, it's interesting that over a period of around 20-25 years, we have done surveys. The University of Gothenburg has done surveys asking people how they look upon profit into the tax-financed welfare services. And they get the same result during the whole period. 60 to 75%, it varies there, are saying, we do not think it's a good idea to have a profit-driven, tax-financed health services. So there is a remarkable gap between the people in general and the majority there and the politicians who take the decisions in regional and national parliaments. This is, of course, something to think of. One could say that this is statistical figures. People do not react that strongly. If they protested much more, not being listened to, then, of course, it had been a different story. But they are not. They are fairly passive. And I think that, and now I'm not a scientist, I'm just thinking, I think that it may be that they take for granted that health services are always there when we need it. And they have not really understood what is happening, because most of these inequities that we are describing are pretty invisible for people in general. They can't see it's a difference in quality of care. They can't see that the ones with smaller needs are given priority to those with greater needs, and so on. These are invisible. You need to do a survey to find out, and politicians have to tell them. You cannot see it in everyday life. But even so, it is a little strange that there is such a silence among them, ordinary people. And as I have been a visiting professor at the University of Liverpool, I think you said it in your presentation, even though I couldn't follow your Icelandic, for almost 20 years, I can see a difference with Britain, where they are defending their NHS services by protesting on the streets and being extremely active in working against any change of their NHS. They are proud of the NHS. They feel it is it is free of charge. We have no user fees. Let us protect it. Even though the politicians are very careful when it comes to election. We will not touch upon your NHS. We will keep it there. And then they are not following what they are saying, but that's another business. But there is a movement where people are really engaged in health policy and protecting their NHS. And we, in Swedish at least, we do not have a real word that you can compare with NHS. I mean, if you go out on the street and say, I want to protect the public health services, it's not as the same thing as if you go out and say, I want to protect the NHS, because that is it's something that they are proud of, and we are not really proud of we are critical to the healthcare system in many ways. And we have had that system for a long time, and we know that it has long queues, that it is bad in several respects and so on. So it's a completely different approach from the general public to the health services in Britain and here, or in Sweden. I don't know the situation here in Iceland. So, of course, if one could find a way of mobilizing and really take advantage of the will of the people of having a fair healthcare system and tell them more about what is approaching and partly already there, then of course it had been a different political situation as well. But that is up to, well, all activists, all political parties, and everyone again look at it. Then I would like to move to a little bit more a technical part. And that is one tool for privatization in Sweden that has had a dramatic impact on the whole outpatient care, not the hospital care, but the outpatient care. And it is called the law of free choice. And I will use an abbreviation when talking about it, and that is LOV. That is the abbreviation, L-O-V. And I would like to start with the name, the law of free choice, because it has nothing to do with the right to choose provider. The right to choose provider was introduced in the Swedish healthcare system some 20 years before they began talking about this new law and implemented it. And the reason, of course, why they call it a freedom of choice law is that that is very popular. Everyone wants to have a freedom of choice, while, as I said, a great majority are against profit-driven privatization. So using the proper name, that this is a law for privatization and to have it tax-funded, that would be politically not very smart. So then it's much better to call it a freedom of choice law. And I mean, we know the new language by Orwell, and he couldn't have used it better than the Conservatives did in Sweden, because it's everyone think, even though it has been the right to choose, that it's something new here and greater choice is involved, but it isn't. It's only the fact that it is commercializing the care. And I would like to make a comparison here with the Norwegian system of fastlege, regular doctor, as they call it, fastlege reform in Norwegian, because it shows the difference with two approaches, both being private, providers being the in charge, and both offering choice, but so different in terms of commercialization. And if we take the Norwegian one first, I say, how do they decide about how many health centers should be built and financed by tax money, and where should they be located? Well, in Norway they say, of course it's the commune who will decide that in a democratic way. and we'll do it according to need. And in the Swedish system of LOV, and also for general private for-profit practices, they say, oh, it's us deciding. It's not the democratic ones. We have the right to decide how many health centers should be built. We are the one to decide where they should be located, regardless of the need of the people in different areas. And can you imagine a situation where you hand over the democratic rights? I like your face there. I mean, falling down. Is it really like that? It is like that. Sorry. Then the ownership of the health center. In Norway, they say, our health centers, of course, will be owned by us. And when we have a contract, we will have a contract with an individual doctor. And when the contract is finished, and when he, a private doctor, has finished his term in that health center, we take back the health center because it's our health center. And we rent it out again, so to say, to another doctor, and they can run it, this private doctor, but he's embedded very much in the general healthcare system. What do we do in Sweden? We say we sell it on the market. It's open to everyone who gives a bid to buy it. And who is the winners? Big multinational companies and venture capitalists. They are the biggest owners now of private for-profit providers, both in the primary healthcare system and in the specialized care, outpatient specialized care. In the field of hospitals, we have only one big hospital privatized, and that is St. Göran's Hospital. It was bought by a venture company first, by the end of 90s, by a Swedish venture company, Bures was the name, and then was sold to Capio, who was another one with at least some Swedish links. But they sold it then to a French and Australian company, and they are now in the process of selling it again to an American investment company and to the state of Abu Dhabi. And this is so strange. And what is happening? Why are they so interested in buying this? Is it the house? No. There are many houses to be bought. Is it the staff? No, it's not. It is they are trading with the right to get tax financing. That is what they are trading. When we are paying our taxes, we are feeding a system of trading our taxes to Abu Dhabi. And they make profit, good profit. Strange. Then the Norwegians have a cost control. They say we have our financial ceilings, and everyone who is aware of how we are struggling in the public sector know what it means to have a ceiling and a restricted budget and the budget cuts and all that. But in this new system with the private for-profit providers, there are no ceilings. We, as taxpayers, say, we will pay everything that you find profitable to sell. And then they are also saying, isn't it fantastic here we can get everything we sell, we will get tax financed from the commercial side. So there is a huge difference between Norway and Sweden again here. And the democratic control is, of course, functioning fairly okay in Norway, and we have lost a lot of democratic control in the Swedish system. So what I want to make a point of here in this comparison is that it is not really only talking about public and private. It is also talking about how you control the private and how you embed a private provider and define which type of private providers you are willing to accept into your system. I mean, in Britain you have the GP. No one is questioning that, even though many are very much against the commercialization of the system. But the GPs are not seen as part of a commercial healthcare system. They are seen as a part of the general public system. And that makes a big difference. So, what are the main problems then? The effects of what I've just described. And you have it in the little translated booklet, so I will be quite short here. But I still have to repeat the main effects. People with minor rather than major health problems are favored. People with higher education, they increase their risks, their visits to primary health care doctors more than those with a limited education. People living in urban areas are favored rather than those living in rural areas. People living in urban high-income areas are favored rather than those in low-income areas. Reduced economic access. You will hear Rúnar Vilhjálmsson later today talking about the situation here in Sweden. It's a little bit different in Sweden as compared with Iceland. I can understand from the notes we have received from Rúnar. We do not have a major problem with the ordinary user fees in the health services. It's only fairly small groups who suffer in Sweden, except in dental care. But we have the other problem, which is greater, and this is what I've already hinted at, that you have this invisible economic barrier that the private for-profit providers are singling out who is profitable and not profitable. And that is in itself an economic barrier, but it is invisible. You can't see it. You don't know if you are profitable or not. And you don't know how much you are expected to pay, even though you say in these demagogic ways that you are carrying the money and you are a customer on the new market and you have more power and all that. That is, of course, nonsense. If you don't know how much you have and how much you should pay, then you are not a customer on the market any longer. You are in the hands of those who determine whether you are profitable or not. It's very simple. There we have our problem in Sweden, that we have economic access is very much reduced by the ability to sort out, not individuals. They are not saying in the waiting room that you are profitable and you are not. This is done at a structural level. It is done with groups. It is done where you locate. It is done with your marketing. It's done with your opening times. It's done with your specialities. I mean, we have doctors who have specialized in doing only small interventions. And checking only small health problems because they are most profitable. These are the ways they find their way to be profitable and sort us in different categories being. And of course, when you introduce private health insurances, which you do not have here, I understand, to my great happiness that Iceland is the first country I visited without any private health insurances. But in Sweden we have them, and they are of course undermining the public system a lot. They are the private providers, profit providers, they are opening and expanding the market for private financing, and in particular then of course for private health insurances. And many those who say it's good with private for profit, they are very really telling that it is a link to private financing. They even say, no, two different things. We are for public financing. But of course, when you open the market, the private financing is coming in, the health insurance are coming in. So you have a unique chance here to actually stop it, because it's so much easier to do it now as compared as we have 700,000 people with a private health insurance in Sweden. Even trade unions have taken these insurances. And then it is, of course, a major problem to reverse this without having all those people against you as a politician, because they, of course, like their private insurance. It gives them quicker access, and we have long queues. I cannot blame those who take a private insurance and say that they are stupid or that they are destroying. They say, for me, it is very good. I don't have to wait more than 2 weeks to have my surgery. And in the public queue, I have to wait for 5 months or more, perhaps. So take the chance now and say, either as they do in Canada, that you cannot take a private health insurance for services that are in the tax finance system. And they have had that for a long time. Or you could say, as we have proposed to the parliamentarians in Sweden, they haven't listened yet. Well, they have some of them, but not all. Not in a majority anyway. Use the power of the purse. Say, if you want, to the private for-profit providers, if you want to have your services tax-financed, then you can't take with priority people with private insurance. Easy. They would say, of course, we need your money, and if that is the case, then we earn so much more on you because you are so much bigger as a payer as compared with the private insurances, that they would definitely accept it. And we have done that with the Social Democratic majority in Stockholm. They said so to the private hospital St. Göran that I just mentioned, and they agreed. They only got, I think it was 3-4% of their income from private health insurance and the rest from public. So, I mean, of course, if the public is using their power, saying it's a prerequisite, then you win the battle. But no one has done that yet in Sweden. And it is the conservative and neoliberal parties who always say no to these proposals. I would also like to mention another effect that we found during the COVID-19 period. And that is that we couldn't mobilize the resources of those private providers. They could say, we have our contract and we stick to the contract. And this was an unexpected thing. It was not written into their contract. So the whole burden of reorganizing the services were on those who were publicly employed in the public ones. And that was, of course, a terrible burden for them. And if it could be shared with all tax-financed services, it had been a different story. I mean, it had been so much easier as compared with what we had now. Some of the private for-profit, if it was profitable enough, they actually negotiated and said, we can offer you some services. But that was fairly marginal, and at the beginning of the pandemic, and afterwards, after a while, it was not so attractive any longer. So we have a split tax finance system when it comes to mobilizing in emergency cases. And that is a very, very serious thing. And in our times, we don't know what will happen next door or next week or perhaps the next volcano here. But anyway, it's a serious thing to divide a tax finance system so that you can only, by political means, mobilize one part of it. And if that part is then increasing even more, then the problem, of course, increases even more as well. Another thing, quickly mentioned, they often say that private providers have a better quality of care than public. And when you look at many surveys made, you find that they are right. It is a better quality, perceived quality, what people think when you ask them. But it is not because it is private. It is because they are serving different type of patients, public and private. And if you have the same group of patients, if you have public providers and private providers in an underprivileged area or in a rural underprivileged area, they will have the same quality. And the same if you have them in a privileged area. It is one being public and another private. Same quality. So the saying that it is better with private is typically wrong, but it is also typically wrong to assume that private is always worse, which is also an argument sometimes heard, that profit is making it necessary for the private to lower their quality, which is not proven in surveys. Another saying is that it is very cost-effective to use private services instead of public, and it is more costly to have private. Transaction costs are much higher. They have to pay profit out of the resources they have. We have to pay for unnecessary care, which is a cost in itself. We have corruption, it is cost, and it is increasing when you have private for profit. We have tax evasion, which is costly, money is lost. And there are many, many other reasons why it is more costly. Administration is going up. We have 2,000 contracts in Stockholm to be administrated. We have so many conflicts that are going to court, and that costs money because of conflicts between two systems. And all this brings to a definite conclusion that it is much more expensive to have private if you look at the whole picture. And you should always look at the whole picture, all the type of expenses. Then finally, I would like to mention also that trust is really the signal if you want to see if your healthcare system is under threat. And trust is going down in Sweden among low-income groups and those who have a serious disease. And politicians are not really aware of it to the extent that they should. Because I think when trust... Sorry. Jag ringer dig senare. Hej. Trust is... as I said, going down among certain groups that should have the greatest trust because they have the experiences, most experiences, some of them. And there is a Swedish researcher, Professor Bo Rothstein. He has looked at factors which undermine trust in the public system in general. And there you have, for example, that market forces are replacing democratic decisions, that inequities are increasing in the system, that regulations and laws are not followed, and that is very much the case in Sweden. The healthcare law is not followed, and it's sometimes only window dressing because the company law is taking over for the private for profit. They have to follow the company law, and it is much stricter and more compulsory than the healthcare law. So the laws are not following. And then if you have corruption, bribes, and tax evasion, and all these things undermine the system. And unfortunately, we find all these things in the Swedish system. So my conclusion is Commercial providers with market-oriented reforms are influencing the whole tax finance system, not only the size of the private, because they also influence the public very much, as I have illustrated with the COVID case, but also the public are forced to be more like commercial ones in the Swedish system and think in competition terms that they have never done before. So the whole system is influenced. So uncontrolled, profit-driven healthcare services are like a systemic infection in the whole healthcare system. Tax-financed care is poisoned with increasing inequities and costs. And the only way to cure this is to take back the democratic control and to allocate resources according to need. Thank you very much.
Tack så mycket, Göran. Jag känner mig nästan så jag har en liten sten i magen, men kanske kommer det bli bra. Þakka Göran kærlega fyrir upplýsandi erindi. Ég held við bara bindum okkur beint í að fá Ísu hérna upp. Ég ætla aðeins að kynna hana áður. Hún sænskur stjórnmálafræðingur og yfirmaður hugveitunar Arena ED sem styrkt af verkalýðsfélögum. Hún með doktorsgráðu í stjórnmálafræði frá Háskólanum í Vínarborg og hefur reglulega lagt sitt af mörkum við framsakna dagblaði Dagens Arena og Social Europe og hefur starfað sem pólitískur ráðgjafi í sænska utanríkisráðuneytinu. Hún var framkvæmdastjóri International Union of Socialist Youth ára 1997 til 2001 og formaður stjórnar rannsóknarstofnunar fólksflutninga, þjóðerni og samfélög eða REMESO, sem ég vona ég að segja rétt, við Linköping háskóla. En það kann ég, af því þar bjó ég í Linköping. En erindi Lísu heitir Trade Union Strategies and Responses Towards Marketization of Healthcare Services, Perspectives from Sweden. Lisa, the floor is yours.
Tack så mycket. Thank you so much. As someone who has been born and raised in Uppsala, I am particularly proud to be here in the Edda House. As you might know, we are extremely proud to host one of the Eddas, the Uppsala Edda, and we really hope that we can continue to have your trust to guard and cherish this amazing gift. We being in this house, I'm also reminded that Snorre Sturlason left a very important mark in Swedish tradition. He traveled once to Sweden, though traveling at that time was very adventurous. And he actually bringing with him the richness of the Icelandic tradition, the tradition not least of democracy. We went yesterday to the thing. He inspired the first recorded law, the older Västgöta law, with one very famous sentence, "Land ska med lag byggas." This that's in Swedish, but I know you understand it perfectly in Icelandic, showing that what is really important to us, it's common in our languages. I think we have that as a starting point for the way we treat healthcare. Healthcare should be a part of law that we decide together, democratically gathered at a thing. It should not be dictated by the logics of the market or follow the interests of profits. It should be built on the rule of law. Unfortunately, also trade unions have, as Göran was saying, been infiltrated by profit interests. And also this would be part of my speech to you today, a warning from the Swedish side. make sure that you take care of the important role that trade unions can play, and take it as a warning that Swedish trade unions have maybe awakened a little bit late to this important struggle. To be fair, you'd have to know that Sweden has lived through what can be called the age of market. At least this is the name of a book that was published earlier today that I recommend reading. I know many of you speak Swedish and read Swedish. It tells the story of the market turn in Swedish society. Maybe because we were very proud of the Swedish welfare society. Maybe we thought that the Swedish welfare model was so strong that a little market couldn't change. Just a little spice of market thinking, of new public management. Everything would basically stay the same and we will just have a little bit more efficiency. Instead, as Göran has described, the market thinking, the profit interests, enter the system as an infection that we have had problems getting rid of. So trade unions, given this zeitgeist, this tidsanda, I think you understand this word as well, they were generally positive towards privatization. This is an illustrative example from the main Swedish daily newspaper Dagens Nyheter in 1997. They could publish an article together with the slogan, "Let the market take over healthcare." And this was signed not only by the usual neoliberal suspects, but also by the head of the Swedish Medical Association, Läkarförbundet, and also by the chairperson of the Swedish Association of Health Professionals, Vårdförbundet, organizing the nurses. But there has always been a fight, there has always been a discussion. Some of the trade unions were indeed skeptical from the start. This is an answer to this article published a few months later, where the trade unions on the blue-collar side, the workers of the healthcare sector organized in the municipal union, were saying healthcare that is put to the market will be healthcare only for the strong. So this will mean a much less equal healthcare, and they were warning. But it took a while, and I'd like to think that you could save a lot of unnecessary, very problematic experiences if you start thinking systematically about these issues. The sooner, the better. One important thing was an initiative taken by the Municipal Workers Union. They did this not in the healthcare area, but I think the example is interesting. But in elderly care, they were beginning to systematically compare being employed by a for-profit private actor comparing to being employed directly by the municipality. And they looked at working conditions, they looked at pay, they looked at the general satisfaction of working, and they also looked at whether the contracts were temporary or rather permanent. And they could see on all these aspects, if you compare being employed by a for-profit provider or being employed by a non-profit municipality, on all aspects the private was worse. So they had worse working conditions, they had lower pay, and they to a much larger extent had temporary time-limited contract as opposed to permanent contract, which was a part of the catastrophe of the elderly care during the corona pandemic as well, because we had lots of staff at the private providers who worked a few hours in one elderly care home, maybe another few hours in the domestic care service, another few hours in another home, and during the weekend, very efficiently spreading the infection from all these parts. So the Municipal Workers Union have done, the most recent report is from 2022, and as I quote there, they are concluding wages are generally lower, there are more temporary jobs, the proportion of part-time employees is greater, and employees in the private sector are also less satisfied with their workplace. There were also consequences on the local level. And I think when trade unions started listening to the experience of the local level, this also was an important part of changing the position that was at best naive towards privatizations, but also there were trade union representatives, as you have seen, who openly welcomed privatization with the idea sometimes of having a competition between employers. They were thinking, well, if you as an elderly care worker or as a nurse have several employers, the private provider, the state or the region or the communal provider, you'll be able to negotiate better conditions. One example here is from a report that we issued on private elderly care in Lomma, which is a conservative-run municipality in the south of Sweden. They told us one thing that stuck to me. The staff told us that they dragged the elderly out, they set the table very nicely, and then they took a picture for Instagram. And then they dragged the elderly in again, because the point was to make a show on Instagram to lure new old people to sign up for this elderly care home. And you can imagine being an elderly care worker, being proud of your job, actually knowing what you're doing. You've gone to school, you have many years of experience, and you're forced to do this Instagram work instead of actually using your professional experience. So a lot of the trade union contestation of privatization and of this neoliberal way of organizing welfare has come from the local level. The Lomma model is one, where they also managed to convince the mayor of that city. The city has been ruled by the Conservative Party since the introduction of voting rights in the beginning of the 1920s. So it's a deeply conservative municipality, but they've realized you get more bang for the buck, mer pang för pengarna, if you run these services with the municipality instead of privatizing it. Another example of this is Nordanstig. I'm running quite fast through this to leave place for questions, but I'll leave you with the slides for afterwards. Another very important battleground of the trade unions, unfortunately, has been the issue of private health care insurance. So to be clear, as Göran also did, we are not speaking about insurance against a loss of income when you're ill. We are speaking about an insurance that would give you health care with a priority. So basically, stepping in front of the line, getting faster care than other people will get. This is the idea of a health care insurance, nothing else. In a universal system where everyone is guaranteed to get health care, this is the idea of the private health care insurance, to get it faster. The largest Swedish trade union, Unionen, which is organizing civil white-collar workers within the industry, they have almost 700,000 members. They decided, for instance, to sign a private healthcare insurance for their members, not for all the members, but members could take this as a part of their membership, even though it was clear that the private providers gave priority to people with the private health care insurance in front of the people with greater needs who were coming from the tax-paid side. But here, as I said, there's been an important battleground, and here the trade unions of the medical professions, the doctors, the nurses, they have been very clear. This is nothing we should have in the system. We do not want to have to treat people who have lesser needs just because they arrive funded by a private healthcare insurance. We would like, as professionals, as we've been taught in the ethics that we subscribe to treat people according to need and not to the ability to pay. So they have resisted this, and they said we could never think of signing it for our members. And there's been a fight, and now also Unionen have said we would like to revise this policy. It's nothing that we would do nowadays. Here as well, together with LO, that is the equivalent of ASI, the Blue Collar Workers Trade Union Confederation, my think tank has made a report where we have translated international experiences of private healthcare insurance and brought that to a Swedish audience. It's a great book comparing 18 different countries. That I would really recommend. What we did is that we translated just summary pages and provided that to the Swedish debate, and were able to gain also a lot of attention. So this is an ongoing debate, but we are gaining some ground. So I'd say that it's taken us some 30 years. Göran, you didn't mention, but the book that we have summarized and then have been translated to Icelandic is a follow-up of a book that Göran wrote 30 years ago. 1994, he wrote a book entitled The Healthcare Markets of the Future. So he was, at the time, foreseeing this development. Unfortunately, when we decided to publish a follow-up report, he had to name it When Healthcare Became a Market, because actually it happened just as he had foreseen. But now, some 30 years on, I hope that you would save this time. There is some general signs of awakening. One thing that particularly made me happy to know was when the Union of Civil Servants this year decided to adopt their first political program. They didn't have a political program before. They're the union of everyone that is employed by the state on the national level, and everyone that's employed also by the state companies. So we have a number of mining companies that are still state-owned. We have Vattenfall and other companies that are run like private companies, but they're still part of the state. They organize all of them. And they have stated that they are skeptical about market solutions for socially important tasks, and argue that the state needs to take back control, which is, of course, the essential thing that you need to learn here. I think I am running out of time. I just wanted to add two titles to the way that you can think about this. I think in Sweden an important debate has been, how are you organizing welfare services and how are you steering them? So there's been a debate between steering with objectives, telling the elderly care home or the hospital or the healthcare center, we don't care how you do it as long as you fulfill this and this and this objectives. Or are you to be rules-based? Every health center has to have a maximum of 1,000 people per general practitioner. That's a rules-based. The unfortunate experience that we have made is that when you set targets, you open up for the private providers to cut down on staff, cut down on their hours, cut down on the professional skills and the level of skills that you demand from the staff. This is particularly evident in the Swedish school system that has been heavily privatized, where the objective is give the kids some good education, we don't care how you do it. And some schools have decided, well, we'll prepare the kids for university by teaching them in lecture halls, and they can have the rest of the week free and do self-studies. The important thing is that they learn something. If you choose well-prepared kids who have parents who can do their homework, you will still have good results. But of course, it's a crazy thing. the objective-based, target-based steering come with a promise of professional freedom. People were thinking, well, if we don't have to do exactly like the rules, so and so many kids per classroom, so and so many hours of teaching, maybe we could have more professional space. Well, the experience is if you introduce the interest of profit, the professional space will shrink. You will be forced as a professional to take care about generating profits for the company you work for instead of following the ethics of your profession. That's why, particularly in the healthcare, you need to mobilize the healthcare professionals on the side of demarketization, of questioning privatization, now that they see that it didn't give them more professional space, but rather a lot less professional space, alongside, of course, not giving much less space to democracy. So what to do? Well, stop privatization. It's the best thing that you can do whenever it's on the table of the politicians. Just make sure it doesn't happen. You also have to make sure that healthcare services that are public are sufficiently funded and sufficiently staffed. This is a very unfortunate loop that you will be familiar with. You'll have underfunding, so people are unsatisfied. They have to wait long for the surgery. People live with pains or worries. My kid cannot see a child psychiatrist. I am worried about how he's doing. And you'd have privatization proponents using this to say, well, let's have some privatization. We will solve the problems. And you know, underfunding you cannot solve with privatization. Lack of equality, that people cannot get the care that they need, you will not solve it with privatization, because private care is not needs-based, it is profit-driven. But you'd have a loop and you'd privatize, and you realize privatization costs a lot of money. Some money that's leaking out of profit, another money that is used because the services are not organized to cater for the needs of the population, but to cater for the profit needs of the companies. And you also have a lot of bureaucracy because you need to control them all the time. People are unsatisfied again and saying, well, the services are not delivering what we're hoping for, and you have the proponents of privatization going again. Well, let's try some more privatization. Until you have people signing up for private insurance, and people signing up for private healthcare insurance say, well, I'm already paying. Why am I supposed to pay taxes for a service that doesn't work? I prefer to pay everything from my private pocket. And you'd have a very unfortunate loop of increasing privatizations. Try to make sure to stop it in time. Take back control. Also try return services that have been privatized to the public hand. If you want to know exactly the steps and how to do it, I think Swedish trade unions have made a very, very interesting, also very practical experiences. You need to ask the questions again and again, what should and could be run by the public sector. Thank you so much for your attention.
Thank you so much, Lisa. I've been admiring you both. You're such great presentators, and it's also clear. And yeah, but there is something that so much here that I'm looking forward to having questions later on with you. But first we will have Rúnars video. Þannig að núna komið að því að við fáum að sjá upptöku af erindi Rúnars Vilhjálmssonar. Hann prófessor í félagsfræði við hjúkrunar- og ljósmóðurfræðideild Háskóla Íslands og með doktorsgráðu í félagsfræði frá Wisconsin Háskóla í Madison í Bandaríkjunum, þar sem hann sérhæfði sig í félagsfræði með áherslu á heilsuvandamál og heilbrigðisþjónustu ásamt heilbrigðisfræði og áherslu á stjórnun heilbrigðisstofnana og faraldsfræði. Þannig að hann þekkir þó nokkuð vel til þessa málaflokks og hefur árum saman rannsakað skipulag heilbrigðisþjónustu, afstöðu almennings hér á landi til reksturs og fjármögnunar heilbrigðisþjónustunnar og aðgengi almennings að heilbrigðisþjónustunni. Og erindi hans reynsla frá Svíþjóð í íslensku samhengi. Á ég að gera eitthvað eða ykkur Nästa. Og næsta.
Ég vil byrja á því að þakka kærlega fyrir tækifærið að fá að bregðast við mjög þörfu og mikilvægu erindi Göran Dahlgren og Lísu Pelling þróun í félagslegu heilbrigðiskerfi Svíþjóðar, nánar tiltekið einkavæðinguna og hinar ýmsu hliðar hennar. Mig langar til þess að snúa að innleggi hjá mér í tengslum við þessa umræðu og ég hef nefnt að einkavæðingin og áskoranir í félagslegu heilbrigðiskerfi. Nú í bók sinni Jämlik vård, en handlingsplan, ræða Dahlgren og Pelling heilbrigðisþjónustuna í Svíþjóð, sænska kerfið eins og það íslenska og raunar önnur norræn kerfi teljast félagsleg. Slík kerfi hafa eftirfarandi einkenni, í fyrsta lagi almennur réttur til heilbrigðisþjónustu, öðru lagi að kerfinu ætlað að tryggja jafnt aðgengi að þjónustunni, sem á fyrst og fremst að vera fjármögnuð af hinu opinbera, sem skipuleggur þjónustuna. Nú, hið opinbera greiðir þjónustuveitendum fyrir þessa þjónustu, notendur hafa lítinn eða engan kostnað af henni og hið opinbera á að mestu aðstöðuna sem notuð og rekur helstu rekstrareiningar. Og það gjarnan veitt heimild til takmarkaðs einkareksturs og þjónustu og einstaklingar borga þá kostnaðarauka sem af því getur hugsanlega leitt. Nú í bókinni þá ræða Göran Dahlgren og Lísa Pelling einkavæðingu í heilbrigðisþjónustunni í Svíþjóð. Nú með einkavæðingu átt við í fyrsta lagi sölu eigna, þegar að ríkið selur frá sér eigur, aðstöðu, húsakost og svo framvegis til einkaaðila. Og í öðru lagi að ræða aukna einkaframkvæmd og við köllum það einkarekstrarvæðingu sem hluti einkavæðingar. Í þriðja lagi aukin einkafjármögnun, svo sem aukin sjúklingagjöld eða auknar einkatryggingar teldist líka til einkavæðingar. En það þó einkum annar liðurinn sem að til umfjöllunar í bók Dahlgren og Pelling, þó einnig sé komið inn á þriðja lið. Nú áskoranir eða vandi sem að tengist einkafjármögnun í félagslegum heilbrigðiskerfum nokkur. Í fyrsta lagi að þá getur einkafjármögnun eða sjúklingagjöld leitt til frestunar eða niðurfellingar á heimsóknum til þjónustuaðila. Þetta mjög vel þekkt í rannsóknum. Einkafjármögnun eða sjúklingagjöld geta valdið ójöfnuði aðgengi að þjónustunni og aukið mismun eða misræmi í milli þarfa og notkun heilbrigðisþjónustu milli hópa. Og þótt þessum gjöldum sem jafnan ætlað að auka kostnaðarvitund, þá má vissulega spyrja til hvers ætti að auka kostnaðarvitund sjúklinga. Nú, það jafnan gert ráð fyrir að sjúklingagjöld dragi úr óþarfri þjónustunotkun en ekki nauðsynlegri hjálparleit. Þetta virðist hins vegar ekki ganga eftir, meðal annars ekki í íslenska heilbrigðiskerfinu því að langveikir og þeir sem glíma við fjölkvilla, þeir fresta læknisþjónustu oftar heldur en aðrir. Einkafjármögnun í formi einkasjúkratrygginga svo önnur tegund af einkafjármögnun sem skapar forgangshópa sem fara fram fyrir í biðröðinni eftir heilbrigðisþjónustu. Þessir hópar búa þó oft við vægari heilsuvanda heldur en þeir sem bíða lengur. Og þetta meðal annars fjallað í bók Dahlgren og Pelling. Það eru líka áskoranir eða vandi sem að getur tengst einkaframkvæmd. Þó oft sé haldið fram að einkaframkvæmd breyti litlu þjónustuna. Þá getur maður spurt af hverju ætti þá að vera einkaframkvæmd ef svo væri. En ýmislegt getur þar verið að ræða samt. Í fyrsta lagi þá tengist einkaframkvæmd oft innleiðingu eða hækkun á þjónustugjöldum og Þetta sjáum við til dæmis í sérfræðiþjónustunni hér, þjónustu sérgreinalækna þar sem að sjúklingar greiða hærri gjöld heldur en í heilsugæsluþjónustu sem í opinberum rekstri eða einkarekstri. Í öðru lagi þá má segja að þjónustusamningar við einkaaðila í heilbrigðisþjónustu eru jafnan mjög flóknir og þeim oft ábótavant eins og margar rannsóknir hafa sýnt. Til dæmis þegar kemur að gæðum umsaminnar þjónustu, gæða eftirlit yfirleitt mjög takmarkað og gæða skilgreiningin oft hæpin eða takmörkuð. Viðurlögum við frávikum í samningum oft ekki fylgt eftir og hafa litlar afleiðingar. Þriðja atriðið að aðilar í einkaframkvæmd þeir veita sjaldnast heildstæða þjónustu. Flókin og erfið tilfelli og meðferðarmistök einkaaðila lenda gjarnan hjá opinberum þjónustuaðilum og það má segja því að einkarekin þjónusta í félagslegu heilbrigðiskerfi hún starfar gjarnan í skjóli eða baksviði hinnar opinbert reknu þjónustu. Einkaframkvæmd í fjórða lagi beinist of að meðhöndlun einstaklinga eins og oft hefur verið bent á fremur en stærri lýðheilsuverkefnum og samstarfsverkefnum. Og þetta tengist samkeppnisáherslu einkarekstursins að verulegu leyti. Einkaframkvæmd getur leitt til ósamhæfðrar og ósamfelldrar þjónustu þegar margir ótengdir aðilar veita afmarkaða þjónustu í samkeppni hver við annan. Og þar vitna ég meðal annars í Göran Dahlgren. Aðilar í einkaframkvæmd til velja sér jafnað að starfa í þéttbýli, frekar en dreifbýli og sinna síður sjúklingum með mikil veikindi og þjónustu þyngd, samkvæmt sænskum rannsóknum og fleiru. En þessi sjúklingar ættu einmitt að hafa forgang fram yfir aðra, þar að segja þeir sem veikar eru. Að lokum má nefna að einkaframkvæmd dregur almennt ekki úr heildarkostnaði við heilbrigðisþjónustu. Getur þvert á móti aukið hann og þar koma til kostnaðarliðir eins og hástjórnunarkostnaður innan fyrirtækjanna sem reka þjónustuna, arðgreiðslur út úr þeim og aukinn kostnaður eftirlits aðila. Aðeins einkarekstravæðingu heilsugæslunnar. Hún hófst hér fyrir töluverða alvöru upp úr miðjum síðasta áratug og hafði ákveðin markmið. Henni var ætlað í fyrsta lagi að bæta nýliðun í hópi heimilislækna, í öðru lagi að auka valfrelsi sjúklinga lækni og þjónustustað, í þriðja lagi að bæta aðgengi sjúklinga að heilsugæsluþjónustunni, í fjórða lagi að auka gæði heilsugæsluþjónustunnar og í fimmta lagi að mæta betur þörfum fyrir heilbrigðisþjónustu. Á næstu slæðum að þá skulum við skoða nokkuð þessi atriði. Fyrst bætt nýliðun. Einkarekstravæðingin hefur haft lítil áhrif á nýliðun heimilislækna sem slík og ein og sér. Hins vegar hafa heimilislæknar í mörgum tilfellum flutt af opinbert reknum stöðvum yfir á einkastöðvarnar. Þannig að það hefur orðið vart við verulega tilfærslu þarna á starfsvettvangi hjá læknum sem áður störfuðu við opinbert reknum stöðvarnar. Annað þetta með aukið valfrelsi sjúklingum lækni og þjónustustað. Það vart hægt að tala frjálst val sjúklinga í þessu sambandi. Það hefur verið algengt að sjúklingar flytji sig til síns heimilislæknis, færi hann sig á einkastöð. Þannig koma sjúklingar í veg fyrir að lenda á löngum biðlista á sinni heilsugæslustöð eftir að einkarekstravæðingin hefur hafist. Þessi sjúklingar velja því ekki einkastöðina út af fyrir sig, heldur færa sig með heimilislækninum á þessa stöð. Bætt aðgengi að heilsugæsluþjónustu. Athuganir hérlendis sýna að hlutfall einstaklinga sem frestar læknisþjónustu sem þörf á hefur ekki lækkað, aukist heldur. Ég kem að því betur hér á eftir. Þeim hefur einnig fjölgað sem frestar læknisþjónustu vegna þess að þeir fá ekki tíma hjá lækninum nægilega fljótt. Og þessu vík ég aftur á eftir. Fjórða atriði aukin gæði heilsugæsluþjónustunnar. Það ríkir óvissa áhrif einkarekstrarvæðingarinnar á gæði heilsugæsluþjónustunnar. Gæði hafa raunar að sáralitlu leyti verið mæld eftir breytingarnar á heilsugæslunni. Einn afar takmarkaður gæðamælikvarði endurtekið notaður, nefnilega ánægja sjúklinga með þjónustu heilsugæslunnar. Sá mælikvarði einfaldur í sinni mælingu og snýr að upplifun sjúklinga, en nær að litlu leyti yfir fagleg gæði þjónustunnar, hvað þá skipulag hennar. Og þessi ánægja sjúklinga hefur raunar farið lækkandi á höfuðborgarsvæðinu, samkvæmt nýrri skýrslu Sjúkratrygginga. Nú að þörfum sé betur mætt fyrir heilsugæsluþjónustuna, því til að svara að það tekið tillit til þarfa í núverandi greiðslulíkani heilsugæslustöðva. Það þýðir þó einungis að heilsugæslustöð fær meira greitt frá sjúkratryggingum ef sjúklingur sem nota stöðinu talinn hafa meiri þjónustuþarfir. Hins vegar framboð þjónustunar ekki kerfisbundið skipulagt í samræmi við þjónustuþyngd eða þjónustuþarfi íbúa á einstökum þjónustusvæðum, eins og Dahlgren og Pelling leggja eindregið til. Því verður til misræmi milli framboðsþjónustu og þjónustuþarfa á einstökum svæðum. Hér erum við með samskonar vandamál og við að glíma í heilsugæslunni í Svíþjóð og ég ber það örlítið saman hér á eftir. Það má því segja að það liggi ekki fyrir að þörfum íbúa höfuðborgarsvæðisins hafi verið betur mætt með einkarekstrarvæðingu innan heilsugæslunnar. Nú það munur á einkavæðingu heilbrigðisþjónustunnar á Íslandi og í Svíþjóð. Í fyrsta lagi má nefna að sérfræðiþjónusta eða þjónusta sérgreinalækna í mun meira mæli veitt í einkarekstri á Íslandi en í Svíþjóð. Þrátt fyrir að einkastofurekstur sérfræðinga í Svíþjóð hafi aukist. Opinber göngudeildarþjónusta sérgreinalækna á Íslandi mjög vanþróuð. Og þarna kemur líka til að sjúkrahúslæknar eru í háu hlutfalli hlutaráðnir og hafa á sama tíma stofurekstur með höndum hér á Íslandi, en slíkt mun fátíðara í Svíþjóð, þar sem að slíkir læknar eru alla jafna í fullu starfi á sjúkrahúsi. Nú annað að einkarekstrarvæðing heilsugæslunnar í Svíþjóð á opnum markaði að uppfylltum lágmarkskröfum til rekstraraðila, en bundin lágmarkskröfum og samþykki heilbrigðisráðherra á Íslandi. Auðveldar því að reisa skorður við einkarekstri heilsugæslu á Íslandi, en í hvorugu landinu hefur þó tekist að samræma framboð þjónustunnar og þjónustuþarfir íbúa. Það ekki gert með skipulögum hætti, hvorki á Íslandi né og enn síður raunar í Svíþjóð. Nú varðandi einkafjármögnun þá hún meiri á Íslandi heldur en í Svíþjóð. 16% af heildarkostnaði vegna heilbrigðismála borin af einstaklingum á Íslandi á móti með beinum útgjöldum en 14% í Svíþjóð samkvæmt upplýsingum frá OECD. Nú aðeins aðgengi að þjónustu sem mikil áhersla á réttilega svo í bók sem sagt Dahlgren og Pelling. Og ég mun þá sérstaklega beina athygli hér að íslensku aðstæðunum. Nú hér spurt, einstaklingar hafa í landskönnunum verið spurðir hvort þeir hafa frestað læknisþjónustu sem þörf á síðastliðna 6 mánuði. Og 2015 var þessi spurning lögð fyrir í stóru úrtaki og gerðu samanburður á Reykjavíkursvæði og landsbyggðinni. Þetta var áður heldur en að umrædd einkarekstrarvæðing innan heilsugæslunnar á höfuðborgarsvæðinu eða Reykjavíkursvæðinu átti sér stað. Og síðan árið 2023 þá gerði Félagsvísindastofnun aftur athugun þar sem meðal annars var spurt frestun læknisþjónustu sem þörf á eftir 6 mánuði. Og þetta eru fullorðnir einstaklingar 18 ára og eldri sem þarna svara. Og 2015 þá sjáum við að frestunarhlutföllin eru þetta í kringum 21,6 til 29 þarna samkvæmt þessum mælingum, rétt undir 22%, en hafa heldur hækkað þessi frestunarhlutföll og þó heldur meira á Reykjavíkursvæðinu árið 2023. Nú ef við skoðum uppgefnar ástæður frestunar samkvæmt sömu könnunum og þó sérstaklega hér þá könnuninni frá 2023 að þá berum við hér saman Reykjavíkursvæði og landsbyggð og þá koma athyglisverðar niðurstöður í ljós. Það var meira það að þeir sem frestuðu á landsbyggðinni nefndu að þeir teldu að ferð til læknis myndi ekki gera mikið gagn. Þetta endurspeglar munin sem á aðgengi að sérfræðilegri læknishjálp á landsbyggðinni samanborið við Reykjavík, þar sem sérfræðingarnir halda sig fyrst og fremst. Það er að segja sérgreina læknarnir. Aftur á móti er á hinn veginn sá munur að þegar spurt kostnað þjónustunnar þá eru mun fleiri í Reykjavík sem nefna að kostnaður þjónustunnar hamli eða hafi hamlað notkuninni eða valdið frestuninni á heimsókninni. Og það sem að vekur mesta athygli hér, það hversu margir á Reykjavíkursvæðinu nefna að þeir hafi ekki getað fengið tíma hjá lækninum nægilega fljótt. Þetta eru 51% ástæðna sem að þeir sem fresta gefa skýringu, samanborið við 38% sem nefna þetta sem skýring á sinni frestun á landsbyggðinni. Við erum hér þá, þetta endurspeglar verulegan vanda í sambandi við aðgengi að þjónustu sem snýr ekki bara að kostnaði á Reykjavíkursvæðinu heldur líka bið eftir að fá tímanlega þjónustu. Ef við skoðum útgjöld heimila vegna heilbrigðismála og þá allt með talið. Þetta eru útgjöld sem ekki bara snúa að útgjaldaliðum sem að sjúkratryggingar taka þátt í að greiða. Heldur varðar þetta sem öll útgjöld sem lúta að heilbrigðismálum og þarna inni eru lyf, hvort sem að sjúkratryggingar taka þátt í greiðslu þeirra eða ekki, heimsóknir til heilbrigðisstarfsmanna, hvort sem að þeir eru á samningi eða ekki við sjúkratryggingar og þarna eru tæki og lyfjabúðavörur þó að þær séu ekki allar í endurgreiðslu hjá eða kostnaðarþátttöku hjá sjúkratryggingum og sjúkraflutningar og þjónusta annara heldur en lækna sem eru ekki endilega á samningum. Ástæðan fyrir því að svo víðtæk athugun var gerð var til þess að reyna að átta sig á því hvert heildarumfang heilbrigðisútgjalda heimila eru, burtséð frá því hvað ríkið ákveður að taka þátt í að greiða. Það eru auðvitað stórpólitískt mál á hverjum tíma í hvaða mæli ríkið tekur þátt í þessum kostnaði. En það mikilvægt að átta sig á heildarumfangi hans, hvað heimilin varðar. Og þessi útgjöld eru auðvitað umfram þau heilbrigðisútgjöld heimila sem að varða hlut þeirra í gegnum almenna skattheimtu. Þetta eru bein útgjöld þar fyrir utan. Við sjáum það að heimilin vörða meðaltali 244.000 króna vegna heilbrigðismála árið 2022. Þetta meðaltal, sum mikið hærri upphæðum, aðrar önnur heimili lægri. Og við sjáum það líka að ákveðin heimili vörðu hærri upphæðum heldur en önnur. Við sáum að heimili fólks á miðjumaldri varði hærri upphæðum, heimili sem voru mannmörg vörðu hærri upphæðum heldur en sem svaraði meðal heimilinu, heimili atvinnulausra, þau vörðu líka hærri upphæðum heldur en meðal heimilið og ég tala nú ekki heimili langveikra og öryrkja eins og þarna sést, en hæst útgjöld höfðu heimili öryrkja 323.000 á ársgrundvelli. Nú, hér skoðum við síðan hlutfall heildarútgjalda heimilis af ráðstöfunartekjum heimilis og þetta köllum við útgjaldabyrði. Og við sjáum þarna að í heild að þá hlutfall heilbrigðisútgjalda af ráðstöfunartekjum heimilis 4,3%, það er að segja í heildarhópnum, en svo eru ákveðnir hópar sem að bera hærri hlutfallsleg heilbrigðisútgjöld. Heimili yngri einstaklinga bera hærri gjöld hlutfallslega, heimili einhleypra og einstæðra foreldra bera hærri útgjaldabyrði vegna heilbrigðisþjónustu, mannmörg heimili, heimili grunnskólamenntaðra og síðast en ekki síst, heimili lágtekjufólks, atvinnulausra og öryrkja. En hæst voru hlutföll tekjulágra og atvinnulausra í þessu sambandi. Og við sjáum hér tengsl útgjaldabyrðinnar og aðgengis að heilbrigðisþjónustu. Við sjáum það að þegar útgjaldabyrði heimilis er 1% eða minna, að þá eru frestunarhlutföll vegna læknisþjónustu hjá heimilismönnum í kringum 15%. Það eru 15% þá heimilismanna sem að 15% heimilismanna á þessum heimilum sem fresta læknisþjónustu á 6 mánaða tímabili. Það miðast í frestun á 6 mánaða tímabili. Nú þegar að hlutföll útgjalda fram að þessu eru orðin 2-5% af ráðstöfunartekjum heimilis og þá snar hækkar hlutfall sem að frestar á heimilinu. Og við erum komin í 24% þar sem er fjórðungur, tæpur, en hækkar hlutfalli þegar að útgjaldabyrði heimilis er komin í 6-9% og þegar komið er í 10%, þá eru það 45,6% eða hátt í 46% heimilismanna fyrirgefiði sem að fresta læknisþjónustu á 6 mánaða tímabili. Þetta eru mjög sláandi niðurstöður tengsl útgjaldabyrðinnar og frestunar læknisþjónustu. Við skoðum líka hér það hvort að viðkomandi einstaklingur hafi leyst út lyf í apóteki sem hann hafði fengið ávísað og við sjáum þar að þar hækkar líka hlutfall þeirra sem leysa ekki út ávísuðum lyfjum mjög eftir því hver útgjaldabyrði heimilisins vegna heilbrigðismála hefur verið fram að þessu. Hæst hjá þessum efsta hóp sem með 10% eða meira af heilbrigðisútgjöldum vegna heilbrigðisþjónustu, þar eru það fjórðungur sem að á þeim heimilum sem að frestar eða leysir ekki fyrirgefið út ávísuðum lyfjum. Nú, hver eru verkefni framundan í íslenskri heilbrigðisþjónustu? Svona í ljósi þess sem hér hefur verið talað Já, ég vil nú nefna þarna 5 atriði, þótt margt fleira mætti auðvitað tína til. Í fyrsta lagi þarf að draga áfram úr heilbrigðisútgjöldum heimilanna, ekki síst heimila lágtekjufólks, einstæðra foreldra, langveikra og öryrkja. Í öðru lagi þarf að halda einkarekstrarvæðingunni í skefjum. Rök fyrir einkarekstrarvæðingu geta ekki verið þau ein að bæta afkomið af starfskjör einstakra heilbrigðisstarfsmanna. Í þriðja lagi þarf hið opinbera að bera ríkari ábyrgð á heilbrigðisþjónustunni, bæði skipulagslega, fjárhagslega og rekstrarlega. Og í fjórða lagi að þá þarf að líta til þjónustu þarfa og heildarhagsmuna þegar heilbrigðisþjónustan er skipulögð, alveg eins og Dahlgren og Pelling leggja ríka áherslu á. Í 5. og síðasta lagi þarf að draga úr bið og biðlistum í opinbert rekinni heilbrigðisþjónustu með endurskoðun fjárveitinga, bættri aðstoð á mönnun og þetta felur einnig í sér að nýta betur starfskrafta annarra heilbrigðisstarfsmanna en lækna. Það er hægt að draga úr biðlistum eftir læknisþjónustu með að nokkru leyti með eldri þjónustu annarra heilbrigðisstarfsmanna, bæði sálfræðinga og í tala nú ekki hjúkrunarfræðinga innan heilsugæslunnar. Það mætti segja margt fleira öll þessi atriði en ég þarf víst að láta staðar numið hér og þakka ykkur fyrir áheyrnina.
Já, við Við þökkum Rúnari fyrir þetta og koma að Göran og Lísa hérna aftur til mín af því við höfum smá tíma fyrir spurningar. Ég held að sé ekki hægt að sleppa þessu góða tækifæri að fá að spyrja úr. Er ég að fara að taka þennan mæk eða hver ætlar að labba í sal eða á einhver að koma að hinga upp og spyrja þau eða? Fólk spyr og ég endur tek spurningar. Gott mál. Þá er ég að hugsa að is it okay by you if we take a few questions and then you answer, or do you want like one and one? Do you prefer that?
You take several, yeah. Ja, vi kan ta flera frågor samtidigt. Vi kan ta flera frågor samtidigt.
Okej, bra. Þá keyrum við það þannig. Þið eru aðeins hvort þið talið ensku eða íslensku. Ég þá flytt fréttirnar yfir, ef svo ber undir. Og ég ætla að taka saman nokkra spurningar og svo svara þau. Byrjum þar á fyrsta reynsli. Eitthvað sem að, já, alveg svo.
Thank you very much, both of you, for your interesting and important talks. You didn't mention brain drain from the public to the private sector. Has this been a serious problem in Sweden?
Fleiri? Já, gjör svo.
Yeah, hi, my name is Taylor. I'm the chair of the Welfare Committee of Alþingi. What was like the beginning drive for the privatization in Sweden? Was it coming from the doctors that wanted to go into running their own clinics, or were there other forces that were influencing that? Thank you. And thank you for a great talk.
Takk. Fleiri? Já. Ég trúi ekki að það er ekki fleiri spurningar. Mér langar bara að hafa þetta í viku, sko. Já, gjör svo vel.
I was just wondering about the rights of patients, like access to complaining, to follow. If you're dealing with several private actors on the state, what happens to the patient rights?
Já, gjör svo vel.
Thank you for very good presentations. I want to ask you about co-payments in Sweden. Do they differ from what social class you belong to? The disabled, the low income, the high income, more educated, less educated, the co-payments of how they affect you, the co-payments in the health service.
You mean the fee that you pay
yes,
the private?
The fee.
So maybe I'll just loosely say it in Icelandic for those who are listening there. Sko, ef ég skildi þið rétt Alma, þá varst þú að tala sko raunverulega flóttan af fólki, atgerðisflóttan frá opinbera yfir í enga. Já, fór rétt með það og Steinun, þú varst að spyrja raunverulega hver er hvatinn, þú veist, hver er svona hafa drifið þessas hvað maður að segja, áróðurinn áfram hvort það sé frá læknum eða öðrum í Svíþjóð. Svo var spurning sko varðandi réttindi sjúklinga, hvað áhrif það hafi. Og ef ég skildi þér rétt Gunnar alls en þetta pæla í svolítið út frá fjölþættri mismunun og svona auknum kostnaði vegna mismunandi stöðu eins og vegna fötlunar eða...
Já, við sáum svo við í glærunum frá Rúnari að kostnaður heilbrigðisþjónustu að koma misþungt á einstaklinga. Já, kostnaður
heilbrigðisþjónustu að koma misþungt á sjúklinga, já.
Það ég reyna að spyrja hvort þið geti gefið einhverju mynd hvernig þið er.
Já, þannig að vonandi gefa mynda af því. Are you ready?
Yeah, I can start.
Yeah? So, do I do it for the broadcasting, or what do we do here about the sound for the... Yeah, is it okay if you step up to the mic?
Step up to the mic, yeah. This question of brain drain is a very serious problem, because even though doctors and nurses subscribe to ethics, and most of them are very loyal to the patients, loyal to their jobs,
The private sector can sometimes offer very nice working conditions. In Stockholm, we have a crisis when it comes to midwives. Midwives, barnmorskor, they tend to have to work very long hours, and in the night, I don't know why, but also my 4 kids were born at 4 o'clock in the morning. That's when kids like to come out, and that's when midwives have to work. It's a hard work, and there have been many cuts to this part, maybe because midwives are particularly loyal to the birth-giving mothers. They put up with anything to continue this amazing job. But you'd have private clinics setting up within what Göran explained, the law of freedom of choice. They can locate themselves where they want, because the idea is that you should be free to choose, and if patients want to choose to go to a clinic in the middle of central Stockholm, that's where you're supposed to open it. And they can tailor their offer to very easy patients. So normally they will cater to 32-year-old women who have almost no problems, totally normal pregnancies, and they come during office hours. It's very difficult for the hospitals to compete. And our argument has been, if you are funded by taxpayers' money, if you're a midwife and you received your education through the tax-funded system, you should also be obliged to do the hours in the hospital. Why should the night shifts only be taken by those that work for the public? And the private, who are also tax-funded, should not do the night shifts. And this was, as Göran explained, also particularly dramatic during the corona pandemic, because everyone in the hospitals had to do not only night shifts, but they worked for weeks without any free time at all. You remember, right? And the people in the private clinics, they were sitting around having nothing to do. Yeah. Not only this, and this, it still makes me so upset. So many things to be upset about the corona pandemic, but this is the worst thing. Their organization, the branch organization of private healthcare providers in the primary sector, Vårdföretagarna, they wrote to the politicians and said, we are losing money because we have no visitors. We cannot send our bill to you as we used to do. The billing is on the basis of how many patients you receive. Can we please get, for April, May, and June, the same amount of money that we used to get before the corona restrictions? Guess what the conservative politicians did? In the name of competition, in the name of private alternatives, they saved those health centers from going into bankruptcy by giving them the money. So instead of sending them up to the hospital where people were working days on end, night and day with this terrible protection gear, you remember how the healthcare personnel were suffering. And their colleagues in the private clinics were sitting like this and saying, please pay us to continue to stay idle. I cannot, I wish, as an illustration, I made this example up, because to me it's so clear, but I didn't. So, Göran.
Well, the first question about brain drain. We have a serious brain drain. And it goes in many, many different channels, actually. In addition to what Lisa said, if you look at the brain drain, that when you transfer, say, a health clinic into a public, then usually the people working there just follows. And one could say that that is a kind of brain drain, but it doesn't really affect that much, because it's the same people working with the same things, but the owner is a private instead of an owner. But it is, of course, an increase on the private side. But it's much more difficult with those who, for example, start up instead, as if we take the digital doctors that we have, they found a loophole in the privacy law that they could get tax financed without any political decision at all by being having a subcontract with a private for-profit provider, say a health center, in this system. So by being that, they could do something that had nothing to do with what the health center did, because they had these services all over Sweden, just a telephone call, and they got financed for that. Of course, that was a very attractive thing for doctors. They could be wherever they wanted. They could choose working hours. They could sit with only a telephone and a computer, and they could earn a lot of money. So instead of working in a more regular way, this was a fantastic option for them. So there you had a direct brain drain. Then, of course, you had a terrible drain also on financial resources, because instead of paying for need-based services, you paid for very often very unnecessary services. And there was no financial limit. While the health centers had a financial limit, every call had to be paid from tax money, from the region they were calling. So here was a double drain on resources. Then, of course, there is another, perhaps even more difficult to handle, and that is that when you get an unequal distribution of any facility, be it health centers or be it specialized clinics, and they are all concentrated, say, in the inner part of the city, it becomes like a magnet. They want people, and people are eager to get jobs there because it's a nice location rather than in a suburb with problems or in a rural area which is not so attractive. So you have a very magnet, and you cannot compensate that with digital care and other things. Partly you can do that, but not really. So that is the structural changes in the system creates by itself a brain drain of both financial and of personnel. So these are a few examples. Probably I could find some more, but just a short answer is yes, it's a tremendous drain on personnel. Which was the other question you took?
The beginning, what was the drive in the beginning for the privatization?
Doctors that kind of
it was not. Well, of course, we had the Doctors Association in Sweden. They have always been in favor of private for-profit care. So in that sense, they never protested, but I would not say that they were one of the main driving forces either. They could have been a very important one for breaking it and saying, take it easy, but they didn't. They were just a little bit neutral, positive, because they had so many members that were privately employed, and they felt excused if but they had even more members who were publicly employed, so they had to balance there. But unfortunately, if you compare with Britain, where the similar organization for the doctors are very much against the commercialization of the healthcare services, and have been, the chairperson has actually been one of the leading persons in fighting for a more equal care. We have nothing similar to that in Sweden. They are much more obedient to the conservative ideas. Well, I could start then perhaps with the other questions. Someone asked also about patients' rights, I think. We are in Sweden having the weakest patient rights in West Europe, because our law is, first of all, only recommending things, and it is not directed to the patients at all. It is directed towards the provider, the regions and the politicians. So we have few operational patients' law. They had a law to reinforce the patient's law in 2017, but they didn't, 15, but it was so weak that when it was evaluated by the authorities in Sweden who do evaluations, they said you have to do it all over again because this is useless. And not in exactly those terms, but the conclusions were absolutely clear, and it was one of the most striking negative reports on a law that I have ever seen from a public authority. What one could do is, of course, to consider, and I have in the book and in our texts and in many other instances actually said we should look into the possibility of having patients' rights in certain areas written into our present law. But that has never been investigated, and being a non-lawyer, I'm not the one to judge how difficult it is. But I can for sure tell you that the argument that these health sector reforms are empowering people, that is a common argument. They say, look here, you discuss at the kitchen table about things rather than sending it to the parliament where you never know what will happen. You are the ones to decide. You can choose by your feet, as we say. And then you can have a counter on where do you go when you want a new health center in an underprivileged area. You have nowhere to go. You cannot express that by your feet. So where you should go is actually to the boardrooms of the big companies, because they are the ones deciding. But they are not welcoming you that much to discuss this matter. It's not your business. So that's about the rights of people. And then there was a question of co-payments. As I said, we have not major problems in Sweden with high co-payments, user fees. They are except in dental care. In dental care, it's a really big problem. So many people are not they cannot afford to have the dental care they need. But in ordinary care, there are groups who have still problems, but they are on the whole quite limited, and it should be possible to fix it somehow with having free care or something. That has not been discussed, but I think it would be possible. And we have, as you know, a ceiling above which you are not paying. And if you are above 85, it's free, and for children it is free. So we are very, very far from the situation where you have, say, in the United States with their commercial system, where high payments is the most common cause for actually having to sell your home or to really get in big, big, big trouble economically. And we wrote an article about this from Liverpool some time ago in The Lancet, and we named it the medical poverty trap. And it is quite common. Einar and I have been working in Vietnam. They had the poverty trap when we started. It was a little less when we left, but it was not thanks to us. But anyway, there 1 million people were pushed below or even lower below the poverty line thanks to, or due to rather, the high user fees they had to pay. So there, introducing public finances was a must to really get going. But fortunately, we do not have a serious medical poverty trap in the Swedish system. You?
No, I'm fine.
Thank you so much. Ég veit ég aðeins að synga upp á tíman ykkar, en þau hafa tíma, hafa þau sagt mér. Þannig að ekki vera hrædd við að bara standa á fætur og fara eða þurfa að sækja börn eða eitthvað annað. Ég eiginlega svona með þöglu augnaráði lofaði Sif allavega einni spurningu, þannig að þá finnst mér eins og ég þurfa að gæta jafnræðis, það nú titillinn á þessu málþingi. Ef einhver annar að brenna inni með eitthvað eitt, já, að þá ætla ég að leyfa einhverjar örstuttar spurningar. Byrjum á Sif og svo það Kjartan.
Var ég spyrir ennsku, að maður spyrir svona
Jú, ég held að bara best fyrir þau á sænsku.
Ja. Jeg spør Dahlgren, som spesialist på folkehelse, og mitt spørsmål kanskje litt I utkanten av deres temaer her, men det gjelder folkehelse. Akkurat I dag så det mulig den svarteste dagen I folkehelse på Island I lang tid. Og det på grunn av at I dag begynner en av de store matvarebutikkene på Island å selge alkohol. Og de selger alkohol som nettsalg, selv om alle vet at alkoholen allerede importert her, på lager og blir solgt ut som I detaljhandel. Og der har vi monopol, sånn som I Sverige. Dere har Systembolaget. Og vi ser at støtten til Systembolaget går opp I Sverige. Altså det sterk støtte til Systembolaget. Men her ser det ut til at vi har hatt I 4 år mer eller mindre nettsalg på disse premisser, som mange mener at ulovlige. Og så kommer det I dag at en stor islandsk matvarebutikk begynner I dag med dette salget. Og dere fortalte oss om hvordan man bruker skattepengene på helse. Og dette jo veldig galt å bruke skattepengene på helse når markedet tar profit av alkoholsalg. Så det mulig at Dahlgren kanskje vil gi oss noen gode råd hva vi gjør nå, vi som støtter folkehelse, og ser på alt dette skje, og det ser ikke ut til at politikken har klart å skjære gjennom dette problem, eller politi og andre institutter I samfunnet, hit tils 4 år.
Tack, så tar vi minst en till. Bör upp Tina.
Ja, tusen tack. Jag är väldigt intresserad av politiken, inte hela, trots det politik, allt vad ni har pratat om. Socialdemokraterna för förra valet, de lovade att ta tillbaka den demokratiska kontrollen över välfärden. Och min fråga tror ni att de kommer att skärpa sig? Tror ni att de kommer lyckas? Och finns det tillräckligt tryck från facket?
Du tar första kanske.
Þetta ekki bara, það enginn að brenna inni, þannig við höfum þetta bara loka spurningarnar og ég gef þeim færi á að svara. Fyrir þeir sem fylgjast með Í streymi, þá var Í fyrsta lagi spurning varðandi lýðheilsu áhrif, bara aukins aðgengi áfengi gegnum netsölu, sem að var einmitt að taka gildi Í dag, skilst mér að verslunina sé að og þá var spurt út Í svona raunverulega hvað stjórnmálafólk geti gert, og svo var það ekki verið að spyrja út Í raunverulega samfylkingu Svíþjóðar, svo Í íslenski þetta, sem hefur sagt alltaf taka aftur, hvað maður að segja, Í tökluna haldirnar á heilbrigðisþjónustunni og velferðinni, hvort það gestirnir okkar fyrirlesararnir hafi trú á því. Ekki svona sirka bát? Takk.
Well, thank you for bringing up a public health issue. It's often forgotten when you are discussing health care. And in general, one could say that the commercialization of the healthcare system is making it much more difficult to have a drive on public health issues. On the specific issues that you asked, it's very difficult for me to really give an advice because I don't know enough about the situation here. Of course, we have a little bit of the same discussion in Sweden, and that is if farms who are cultivating grapes and produce wine should be able to sell from the farm and not via the monopoly. And the Conservatives have been driving this, and they have got it through. But it is fairly marginal, after all. We are not a great wine producer in Sweden, and there are even fewer are selling it. So, I mean, I can only say that I hope that you will be able really to strongly tell that if you start off, I mean, if you look at the statistics with having a monopoly and not having a monopoly, it's so clear that it has major consequences for the alcohol consumption in the country, and that it affects primarily, I mean, with the effect of alcohol, it is like this, that you consume it in different ways, social groups. Higher income groups are drinking a little bit too much every day, and among workers it's more that they drink a lot during the weekends and at certain occasions, but then they are quite sober during working time because they cannot work if they are a little bit tipsy. And these have health impacts on the inequities in health. So when you actually let it free, there will be greater effects on working class people than on high income people at an increase of the total alcohol consumption. And that could be an argument that you have a lot of evidence of saying and can use. And then, of course, one can probably, there must be legal ways of regulating that you cannot go to a shop and call it that you pick up a mail or a box of wine there, as I understand that you are doing. But that is a little bit out of my professional knowledge to know what to do then. The other question was what is happening after the election. And what you refer to is really not the whole Social Democratic Party, but the Social Democrat majority in Stockholm, where these problems, of course, are the most serious with privatization. I mean, they have 39 so-called free choice systems in specialized care. Almost the whole, everything that could go private and be profitable was privatized in Stockholm. That is the easy picture. And they said we'll take back the democratic control of it. But it was not so easy, obviously. They are trying, and that is a positive sign. We have a majority now that also are pushed by the left, and they have signed a contract with the left with, I think it was 40 or so different points, and several of them are how to control the commercialization. But they have, on the other hand, the central party, and they need them for actually coming into majority. So it's a kind of difficult political situation here also to express your own views, because you have, if you want to keep the power, so to say, then you have to also do things that you may not really like to do. One such thing is that they are not raising the question in Stockholm of making it prerequisite to get public funding and not accepting the private health insurance. So the private health insurance is, they protest against that in opposition, but they're very silent now when they have the power. And the reason is that that was a condition to get the Liberal Central Party into the majority, the present majority. But the fault that, and Lisa may have a little bit different view on this. So I think it is interesting that we both present here our views. But I'm a little bit more critical perhaps than Lisa will be. And that is that I felt that if you want to take back the democratic control, then you have to look at the rights you give to the commercial providers and look at the whole system I described and say, this is totally wrong. This free choice system must be gradually taken away as a system because the value premises under it are totally against what we think is a fair system and against the law. But what they are doing now is rather looking at those instances where they have serious problems. It can be too high cost, for example, and that is a popular thing then to try to reduce. So they attack those, and if it is obviously poor quality, that really is a big problem. But this you have to do under all circumstances. But they left the others go, so to say. So it is coming here and there, and it is not always they have a very clear alternative. So next election, it will be very difficult to say that we have actually taken back the democratic control. We have perhaps avoided some things that we under all circumstances should have avoided, being public or private, that it is running crazy with cost and it is bad quality. So it's a little bit critical, but also a little bit positive that they at least are trying and talking about it. And hopefully they can develop something that is more structural. But that remains to be seen. But now we'll hear Lisa here. We have discussed this. So.
We have... I take a minute and then we'll discuss the social democratic strategy outdoors at the coffee break. Now, it's unfortunate. We've had a conservative majority in the Swedish parliament since 2006. So with the Sweden Democrats, a xenophobic but also right-wing party, the Conservatives, the Liberals, the Christian Democrats have been in a majority. We've had social democratic prime ministers since because they have been able to form a majority around the budget, but not to pass legislation. So this is the main reason. But I think still some regions have been governed by the Social Democrats in majority. They could have done more things. And one thing that is very telling is that they have not been able sometimes to understand the mechanisms of the market. You know, how the for-profit providers think and act. One example is the issue of rental staff in the health sector. Would you have that too? So you'd have a lack of staff in the hospital, and then you'd have a private provider says, I can rent you some staff. You'd have to pay twice as much, but I have some nurses here that you can rent. And you'd have to ask yourself as a procurer, the one that rents these staff, how come they can offer them and how come I cannot offer them a permanent position instead? And they have, I think, many regional social democratic politicians bought into the propaganda of this rental company saying, well, the nurses that work for us, they do so because you have such lousy working conditions. That's why they'd like to be rented out with twice as much pay because you offer them such bad conditions. But, you know, they work in the same hospital. They do work in the same conditions. They just get more paid. And here, I think the procurer have to be much stronger. And we've seen in the last few years a dramatic reduction in this rental staff. It's not the correct term in English. I don't know. Hyrpersonal. For the simple reason that the regions have said, let's not compete with the staff. Let's say that we all procure them to the same price, all at the same time, and we forbid the company to phone the individual clinics or the individual healthcare centers. They all have to do it at the central place where we can control the procurement. So this is understanding the mechanisms of the market that social democrats have sometimes been too naive. the same position on private healthcare insurance and say, well, if people sign up to private healthcare insurance, it's because the public service is so bad. We have to understand that people need to do this, and we need to slowly maybe improve the public service, instead of seeing that what the private company can offer is a possibility to jump before in the line, something that the public healthcare can never offer. So they should not be competing with for-profit actors, but control the for-profit actors, or if possible, forbid them. I think that's an important lesson. So much more to say. We're so happy to stay along with you also afterwards for a while.
Thank you so much. Já, það rétt hjá henni, það að næga að taka og ég veit ég búin að synga mjög mikið upp á tíman en ég vona þessu sammála þessari forgangsröðun að þegar koma gestir, svona góða gestir að þá viljum við gjarna nýta tíman. En eins og þau nefndu að þá verða kaffi og kleinur hérna frammi og þá er tækifæri til að spjalla betur við þau. Þannig að ég vil bara að lokum þakka kærlega þeim sem tóku hitan og þungan af undirbúningi þessara fundar, þýðingu þeirra rits og sömuleiðis ykkur fyrir komuna. Bara sjáumst hérna frammi í spjallinu. Já, og það er hægt að taka einstaka bókinu frammi, svo ég gleymi því ekki. Takk.